Hello, and welcome to this episode of In Discussion With from Medical Update Online. Today, I'm talking to Professor Lynn Crismon about pharmacy practice in psychiatry and in the US Public Health Service. Professor Crismon, could you start by introducing yourself?
I'm Lynn Crismon. I'm the Barron Centennial Professor of Pharmacy in the College of Pharmacy and Professor in the Department of Psychiatry at Dell Medical School at the University of Texas at Austin. And my specialty area is psychiatric pharmacy and clinical psychopharmacology.
Can you give us a brief overview of your current role, what your job involves?
And so currently I'm primarily teaching psychiatry and clinical psychopharmacology and pharmacotherapeutics to PharmD students, ethics and professional development to PharmD students. And I also teach in the Child and Psychiatry Fellowship program over in the Department of Psychiatry and do case discussions with their fellows as well. And I'm involved in a good bit of different kinds of service activities as well.
Your work has focused on pharmacotherapy of mental disorders. So my question to you is, why should pharmacists be interested in practice in psychiatry?
Well, first, mental disorders are extremely common, and they create a lot of the morbidity and pain and suffering that people have throughout their lives. And of course, severe mental disorders are also associated with a risk of suicide. And medications are one of the primary treatment modalities for mental disorders, and so it just sort of makes it ideal that pharmacists would be involved, particularly pharmacists who really enjoy interacting with people and communicating.
You were involved in a project called the Texas Medication Algorithm Project. What exactly was this, and what did it involve? Well,
it started in early 1996, and the State Department of Mental Health for the state of Texas pulled together chairs of psychiatry from all the academic psychiatry programs. For the larger programs, they're associate directors for research. And I was the token pharmacist that was asked to come to this meeting. And we talked about the challenges that existed in public mental health care, those individuals that are taken care of by the state or the federal government for that matter, but we were looking at state-sponsored mental health care. And the fact that it takes so long for the evidence that we have from research to actually get being used in clinical practice, and how really the pharmacotherapy and actually all the services were substandard in public mental health care, and particularly in Texas because the funding was very poor, and we didn't have enough money to be able to address all the issues that existed in public mental health care. But we thought we had enough money to address a specific issue. And since a number of us had a real interest in pharmacotherapy and in the really severe mental disorders, we decided to focus on evidence-based practices to improve outcomes from drug therapy treatment of individuals with severe mental disorders, and to give the psychiatrist the support systems that he or she needed so that they could provide better care for those patients. And then a major part was measurement-based care. Traditionally, psychiatrists have assessed patients by interviewing them and getting a sense globally of how severe their symptoms are. But there was increasing evidence at that time, and much more now than there was then, because that was 16 years ago, that if you measure the symptoms and quantify the symptoms, that you can actually get better outcomes, because it's a structured assessment, and you'll see symptoms that you might not have thought about if you just asked more general global questions, and the patient may never had thought to bring up those symptoms as well.
So in fact, it was systematizing the information and providing a framework.
Very much so. It was systematizing and providing a framework for the pharmacotherapy component of treating these patients. And then psychoeducation was a major part as well. We involved mental health consumers to help us identify the needs that families and patients had in terms of their mental disorders and their treatment. And then we designed all kinds of educational programs. We had videos, we had written materials, we had a lot of things that were pictorial, so that we used different kinds of learning modalities to help patients and their families.